80% of patients with first-time seizures have provoked seizures, acute symptomatic seizures, or seizure mimics, not epilepsy. Therefore, it's reasonable in many of these cases to favor a more patient attitude before rushing the diagnosis of epilepsy and starting anti-seizure medication therapy. That said, some patients with significant risk factor for recurrence could be diagnosed with epilepsy and treated with anti-seizure medication from the beginning. Hello, my name is Dr. Antana Faisa. I'm one of the epilepsy physicians at the Mayo Clinic in Florida. My colleague, Dr. Casino, and I wrote a commentary entitled "The Argument for a More Patient Attitude Towards a Single Unprovoked Seizure." This article will appear in the January 2023 issue of the Mayo Clinic Proceedings. Approximately 10% of the population will experience a seizure during their lifetime, while only 2 to 3% will develop epilepsy. Determining whether a first seizure is unprovoked or provoked is essential for the diagnosis and treatment. While those patients with provoked seizures do not require long-term anti-seizure medication therapy, those with 2 or more unprovoked seizures are routinely treated. The practical clinical definition of epilepsy presented in the 2014 ILAE official report is made under the following conditions: 2 unprovoked seizures 24 hours apart, or 1 unprovoked seizure and seizure recurrence probability of more than 60% over the next 10 years, or diagnosis of epilepsy syndrome. The second definition raises the question of whether some risk factor for seizure recurrence after a first seizure are strong enough to allow for the diagnosis of epilepsy and by association, initiation of anti-seizure medication therapy. The 2015 American Academy of Neurology guideline identified 4 clinical variables associated with increased risk for seizure recurrence. These were prior brain insult, epileptiform abnormalities on EEG, abnormal brain imaging findings, and nocturnal seizures. In real-world clinical practice, the decision to diagnose epilepsy or initiate anti-seizure medication therapy following a single seizure is rather complex because it is affected by several psychosocial factors beyond these 4 risk factors. In this commentary, we argued that most patients with first-time unprovoked seizures should not be evaluated and treated as if they have epilepsy. Now, I will outline our reasons for taking this stance. First, those patients without any of the mentioned risk factors for recurrence are unlikely to have epilepsy. In fact, several studies have consistently shown that the risk of recurrence at 5 years in this patient group is less than 30%. Second, if epilepsy already exists, recurrence would occur rather quickly, in most within 3 to 6 months. This has practical relevance since most of these patients are typically evaluated by a neurologist or epileptologist weeks to months following their first ever seizure, at which time they will no longer meet the new definition of epilepsy. That is, if they don't have recurrence by then. Also, by delaying treatment until the second seizure occurs, one will more clearly identify those needing treatment, and for those, the 30% risk of unacceptable side effect from anti-seizure medication is warranted. Another reason for waiting a second seizure is seizure mimics. The diagnostic issue of seizure mimics is one that's frequently encountered by clinicians. In some studies, the incidence of seizure mimics was almost identical to that of epileptic seizures. The 2 most common mimics are psychogenic seizures and convulsive syncope. The misdiagnosis of epilepsy in these patients, unfortunately, carry the risk of iatrogenic harm. Yet another argument for waiting for the second seizure is that the diagnosis of epilepsy, unfortunately, carries all the secondary handicaps and limitations, including stigma, lifestyle limitation, employment, driving restriction, and insurance. General practitioners initially see most of first-time seizure patients, and the mistreatment of epilepsy may remain undisclosed until a video EEG is performed later. And once established, the diagnosis is unlikely to be reversed. I think the ultimate argument against starting anti-seizure medication is that While there are slight reductions in short-term seizure recurrence from immediate treatment, this policy has no measurable effect on long-term outcomes. Also, there is little evidence that a policy of immediate treatment brings any benefits in quality of life. Besides, immediate treatment doesn't seem to impact survival or mortality in these patients. In this manuscript, we have summarized our approach to risk stratification of the patient with a single unprovoked seizure. Also, we have highlighted the risks of epilepsy in patients presenting with a first-time seizure. We encourage the readers to consider these when evaluating the patient with a true first-time seizure. Really, we need further studies to help us make better informed decisions in patients with single unprovoked seizures. First, we need better clinical biomarkers to identify those with epilepsy already. This could be in the form of advanced EEG or brain imaging study. We also need easily applicable predictive clinical models for seizure recurrence. Besides, it would be crucial to determine how long some of these patients need to be on anti-seizure medications once initiated and the risks of anti-seizure medication discontinuation. Thank you very much for your attention. I invite you to read the full article.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.